Come to another prolific surgeon who's been, we grew together. He's been the trendsetter. I always followed him. And he's an excellent surgeon. Dr. VC, it's my great pleasure to invite you to join this with your thinking on your feet.
Thank you, Suhas. Thank you for inviting me for this particular instruction course. I'm not going to talk about difficult cases. I'm going to talk about the day-to-day cases and how you get into trouble and how you can get out of it. Because that is equally very important that you end the day with a good thing. So routine cases, non-routine complications. If you look at this particular case, it's absolutely a routine case and it's proceeding very nicely with incisions and rexes and everything. And sometimes the complication hits you suddenly and wakes you up from your kind of routine thing. Now here you see the nucleus is out, and I formed the chamber with the saline before going into the chamber to do I&A, and then I have to change my hands. But unfortunately this time I don't go into the chamber and I start doing the I&A from the other side. And as I take up the cortex, and I realize that there is something wrong. I see tissues which are not supposed to see. If you see that, and then what has happened? In a slow motion, this is what has happened, which I saw after the surgery, that when I was putting the irrigation in a shallow chamber or a flat chamber, the Descemet membrane detachment took place. So my first worry was that I should not aspirate the Descemet membrane, detached Descemet membrane. So I had to put in some viscoelastic below it in the chamber, and I have some amount of cortex to be aspirated, which I do it under the viscoelastic without disturbing the detached Descemet membrane. And once that is done, then we have the issue of putting the IOL, and I thought that I'm going to put the IOL under saline and not under viscoelastic. So this is, I prepared the IOL, and under the saline, I put in the lens, and the lens has its own thoughts. The fetal position just didn't open up, and the lens, when it opened up under the saline, it opened upside down. So I already had one instrument inside. I put in the another instrument and flipped the lens and put it in the right orientation. Having done this, then you have the problem of putting the detached Descemet membrane back into the place. And we put in a saline, a bubble, but we went through a clear cornea and put in a large bubble and hope that this would settle the matter. Next day, I asked my cornea specialist to have a look. He said there's a little bit of detachment still remaining, and he did an extra amount of air bubble injection. And fortunately for us, this patient settled down after about 4 weeks of time with about 2 or 3 air injections. So my point is that if you take a shortcut at some point of time in a routine case, you will be, you will get something which is very drastic and sight-threatening. So the lesson that I learned was always enter an inflated eye, never enter a deflated eye. So the second part is the pupil expanders, which is our answer to the small pupil cataract surgery. And if you see this particular case, very small pupil, repeated attacks of iridocyclitis, YAC-PI also done. So these cases have become so simple with the pupil expanding devices, and you can see one of them being done here. From a very small pupil, the pupil expands and makes your life very, very easy. The pupil expanding devices are easier to put in and easier to remove, and it changes the whole kind of management of this small pupil. Well, the point is you have to use some pupil expanding devices, whether it is iris hook, whether it is a Malyugin ring, whether it is a BVI Visitec ring, or a B-hex pupil expander, or a Gupta ring. Take your pick, but you use it, please. Because once you use this, it makes your life very, very simple. Mind you, when you begin to use these rings, there are nuances involved in the usage of all of these rings. So they all have their kind of tricks that are required to be learned to efficiently use these rings. And I learned it little hard way, and you can see here one of the videos where, I'm putting the ring in. Most of the time, the three rings, the three hooks get engaged, and it's only the fourth one that you have to put in with your side port incision instrument. And here, when you do this, the fourth one, instead of engaging the pupil border, it goes behind. Now, how do you remove this? Because this is a little bit of challenge. So what we do is we push the one that you see, the other ring, not try to fish around in the unseen areas. So when you just push in the ring, the other ring, the one which is hidden behind comes out. Something similar happened in this particular case also. So don't do anything blindly. That is the take-home message in this. And you will have to learn to put few of the rings before you actually get hang of doing this very efficiently and without creating any problems. Here again, you see one of the rings gone behind the iris. So what you do is, whatever is seen, that you pull it out, and the hook comes out into the picture and gets engaged into the pupillary border. Well, removing the ring also is sometimes an issue. Initially, when we were doing this particular case, one of the very beginning case where glaucoma surgery has been done, and there is a large peripheral iridectomy, and I am just pulling out the ring, but both the arms are not getting into it, but I thought that I would be able to take it out. So I continue to retract the ring. It keeps on twirling on itself, and I thought that I have almost gotten it out. At that particular point of time, the ring decides to flip, and while flipping, it goes into the peripheral iridectomy, one of the hooks. One of the hook goes into the peripheral iridectomy, and I just cannot pull it out. So what I did was, with the scissor, I cut the ring, and then twirl out the hook that is there, engage into the peripheral iridectomy, and then bring it out with the forceps. So you got to be very, very careful, and you got to be thinking on your feet when you get into trouble. And mind you, these rings also can create problems at times. What seems to be a routine case can be a difficult one. But after some learning and all, I am now being able to do this effortlessly and flawlessly, so that we can, not get into the trouble as I used to get into trouble in the earlier days. So removing the ring, what I do is that I see to it that I use a second instrument from the side port, disengage one of the hook, and then pull it out. But while you are pulling out, both the rings have to go into the thing. So choose your pupil expanding device and learn the correct technique of insertion and removal. Makes the life very, very easy. Preloaded IOL. When they came into this thing, we were very, very excited about it. But mind you, this was a case where the patient insisted I should use that preloaded IOL Clarion lens. And you see what happens, and you see how I get out of the trouble. So we put in the viscoelastic, take out whatever they tell us to do, take it out. And this was one with that gas syringe behind, and the plunger starts pushing the lens, but it goes above the lens and comes out. The lens is still inside. So I start wondering, what am I supposed to do? Because there's no standby lens, and the patient had insisted on this particular Clarion lens. So I take a gauze piece to detach the whole thing, and remove it and bring the plunger out, and there you can see the lens is still inside. So then I, look around and I can open the thing, and then the lens is sitting there. You just pick it up, put it into some other cartridge, and push it into the eye. So you need to be innovative, and you need to think what can be done, and there is always some way out. It happens with other kind of an injector system also. It's not that it happens with just one. So, this was very, very peculiar. This is the Hoya preloaded lens, and you put in the viscoelastic, and then when I when I took it out, when I picked it up from the box and made it vertical, the plunger just fell off. And I'll show you in a while that the plunger has just fallen off and the lens is still inside. So there's nothing to push the lens, and again, there's no plunger because it just fell down. So again, you break open and then you put the lens in another kind of injector, and you end the day with an uneventful. So any injector can be dismantled, that is for sure. And therefore, if you get into kind of a trouble like this, you dismantle the injector and remove the lens, put it in another injector. Quite often, simple cases can also become difficult, mainly because the epinucleus doesn't come out. These are mostly the soft kind of cataracts, which you are taking it out. As you keep taking out the pieces, if you can see, the pupil is not as large as it was when you begin with. The pupil is started going down. And then what happens is the epinucleus just remains there and doesn't come out. So there are, so you can retract the iris and go to the periphery, but I would not suggest you to do any of this kind of maneuvers, because as I will show you this thing, that there are simple tricks that can be done. Now here the epinucleus is not coming out, it is still there, and we are stuck. So what to do? So I was just wondering what is to be done, apart from retracting the iris and going into a dangerous area. I just came out and I realized that when I come out, the chamber shallows and the epinuclear plate just comes out. It is so simple and easy, and you can utilize this when you get into trouble with an epinucleus which is just not coming out. But best is to kind of enlarge the pupil whenever it is possible. There you will see me enlarging the pupil, and that solves all the problems. So the take-home message is, whenever the pupil becomes small, you should not proceed, but you should start thinking about enlarging the pupil by injecting epinephrine or adrenaline into the anterior chamber, and you can see how things become so simple from here on. Even you can put in a pupil dilating device at this point of time in case the pupil doesn't respond to the intracameral adrenaline. So never operate or continue to operate on a small pupil. Take a break and find out what you can do about the pupil. If you can dilate the pupil, all your problems can be solved. So pupil can be dilated at any stage of the surgery, and pupil expanders also can be used at any stage of surgery. Be prepared and not get into the trouble. So thank you very much for your kind attention.